A very good afternoon to everyone. So I think there are very few clinicians in the audience, and please forgive me if the talk seems too technical and if it a lot of things don't really make sense. But I think those who are not from a clinical background, you can allow your minds to wander because I will not really be able to simplify things to a great extent because that is how the medical terms go. So I have been asked by AstraZeneca to talk on treatment dilemmas in EGFR mutant lung cancers. So see, for the non-medical audience, what you need to know is that in the past, maybe around 20-25 years ago, lung cancers was treated as a single entity. That everyone has the same kind of lung cancer, treat it in the similar way. Gradually, with better pathology tools, we came to know that lung cancer is not one disease. It is a collection of at least 2 or 3 different diseases, and this was around 10-15 years ago, where we would classify them into 2 main subtypes: NSCLC, also known as non-small cell lung cancer, and SCLC, or also known as small cell lung cancer. That was what, even when we began our training around in oncology around 15 years ago, is what we were taught. But gradually we came to know through more and more research that even NSCLC is not one disease. There are several different mutations, and these are known as driver mutations, which cause the cancer to develop and make the cancer spread aggressively from one organ to another. And amongst these driver mutations, the most common mutation is the EGFR mutation. So that is the topic for today, the dilemma of whether to treat EGFR mutant lung cancers only with a monotherapy, that is a single agent, or to combine it with something else for better patient outcomes. So we will talk about the burden of EGFR mutant lung cancers in general. What are the risk factors and the prognostic factors? What are the challenges that we face when we treat these patients with monotherapy? And what is the evidence or the data we have as of today to treat it with either monotherapy or with combination therapy? Now, if you look at the actual prevalence of EGFR mutant, EGFR mutation rates, what is very striking and which is puzzling researchers across the globe is that in the Asian population, that is in India and in the Eastern Asian population from Japan and China, the prevalence of EGFR mutation rates are much more than what is reported in the West. So in America, EGFR mutation rates are only around 20 to 25%. If you take 100 patients of NSCLC, only around 20-25% will have the EGFR mutation. But this number is much more in India and in the Eastern Asian population. Why this is so is not exactly known. Is it because of the higher levels of PM2.5 present in our air levels here? That is one theory, but it has not yet been conclusively proven. Our analysis from our own hospital data sets indicates that this prevalence is probably even more than 50 to 55%. So this EGFR mutation is located in the tyrosine kinase domain, and this causes, like I said, increased activity of this receptor, leading to continuous cell proliferation, and thereby the cells, they multiply, they divide, and they invade and they spread the different organ systems. So the most common EGFR mutations are these 2 mutations, the exon 19 deletion and the exon 21 L858R point mutation. Okay, and most of the research has also happened in these 2 mutations only because of how common they are. Other mutations have not been as well studied as these 2 mutations. So if you look at the past, I'm talking about almost more than a decade back, the first generation of the EGFR inhibitors, also known as the tyrosine kinase inhibitors or TKIs for short, that is gefitinib and erlotinib, they could not produce very long-lasting disease remissions. So you can see that the median PFS means progression-free survival. That is how long is the cancer under control in your CT scans or your MRI scans or your PET scans. So this was for an average of around 9 to 10 months or 9 to 12 months at the most. With further advancements in drug development, we got the second generation of EGFR inhibitors, which again did not show a very significant difference in efficacy from the first generation inhibitors. But with the third generation of EGFR inhibitors, that is osimertinib, which is the current standard of care even today anyone in the clinic comes to me with this mutation, this is the medicine that I would advise them. That is osimertinib, which showed its efficacy in the FLORA randomized trial. That achieved a median disease control of around 18.9 months, which was much more than the first generation EGFR TKIs. And this became the global standard of care. Now, the entire concept of combining these medicines, because these medicines, they work well, but of course, it's not perfect. As you see, these medicines, they do not produce remissions lasting for several years. They have their own shortcomings. So researchers thought, why not combine these TKIs with chemotherapy? Because in the pre-TKI era, the only drugs that we had to treat these cancer patients was with chemotherapy. And chemotherapy also worked, but for a short period. So researchers thought, why not combine the oral medicine with the IV chemotherapy and see whether that improves the outcomes. So there are some mechanisms by which it is thought that by adding these two, they complement each other. Some cells, they are killed by the TKIs, some cells are killed by the chemotherapy. And they thought, let us try to improve the outcomes.